Great discussion about lipid disorders in pregnancy. Our next case is also one, but I don't think we'll have that conversation. This is Anisa. She's a 54-year-old female with hypertension and stage 3 CKD. Her blood pressure is 136/88. Her estimated GFR indicates stage 3. It's 46 mLs per minute per 1.73 meters squared. Her LDL is 84. Baseline, we have it available, was 146. So she has had a 42% reduction from her measured baseline. Currently, she's treated with hydrochlorothiazide, enalapril, and high-intensity atorvastatin, that being 80 milligrams once daily. On the right, we see the 10-year ASCVD risk score. So who here has calculated 10-year ASCVD risk in a patient? Okay. Now, when we look at her risk score, if we put in her numbers, we're going to be probably a little surprised that her 10-year risk is only 2.8%. However, one common sort of problem that we have with calculating 10-year risk score is the cholesterol values that you put into them should be a baseline. And we put in actually her on treatment, her on atorvastatin 80 treatment. So I'm not surprised that her 10-year risk is being calculated at a very low value. If we actually had her pre-treatment or pre-statin values, we can put them in there and get a more accurate picture of her baseline risk, because I'm sure that it's greater than 2.8%. So don't be fooled that when you have low numbers, it might be because you're using an on-treatment cholesterol value when into the calculator. But the question for Anisa right now, this CKD patient, stage 3 CKD, 44 years of age, hypertension, and LDL down to 84 on atorva 80, is what change would you make to her regimen? Would you continue atorvastatin 80 and call it a day? Or would you maybe change to atorvastatin to rosuvastatin 40 milligrams daily? Would you add a bile acid sequestrant, add ezetimibe, or would you add a PCSK9 inhibitor? Which would you choose for Anisa? We have a majority, so most people are adding ezetimibe, but a quarter of patients are deciding to call it a day. Continue atorvastatin 80 milligrams once daily. And then with a little uptake of maybe using a PCSK9 inhibitor. Majority, though, is comfortable in adding the ezetimibe. And I think when you look at this patient, what is driving your decisions? What is it about this patient that concerns you? And I think that we always have to think of patients broadly. She does fit into, from the ACC-AHA approach, she is in a statin benefit group. She's in the primary prevention without diabetes population, which was introduced by Dr. Jones in the introduction. And it really would tell us for patients like this patient, Anisa, she's between the ages of 40 and 75. And her 10-year ASCVD risk is not 2.8%. It is higher. So I'm making a very broad assumption that if we put in her baseline values, that she would be at that 7.5% or greater. And in that case, you would have the option of moderate to high-intensity statin therapy. I guess when we take a step back, we can't be mind readers and look at everything in the past. But this is a woman who is primary prevention. And her provider chose to either start with high-intensity statin therapy or titrate her up to that to get this LDL value of currently 84. Now, she might be a little bit of a hypo-responder too, because you would expect with atorvastatin 80, you probably would at least realize a 50% reduction. But there was an aggressive, I'm interpreting and overall seeing an aggressive approach that I'm thinking is probably appropriate for this patient. And you know, there's other recommendations of when you would just be okay with moderate intensity statin therapy. That could be patients who have a little bit lower 10-year risk scores. I'm not thinking that is actually the area that fits this particular patient. I think one thing that might be driving her aggressive approach might be her baseline CKD. But before we go down that route, I just want to sort of throw out another possibility. Perhaps this clinician was comfortable in aggressively treating Anisa because of data from meta-analyses like this particular one that we are showing you right now that really show a relationship that, based on clinical trials, the lower the LDL achieved, the lower the risk of cardiovascular events. We see that very clearly on the left, that patients treated to an LDL of less than 50, if you look at this forest plot, that they have lower risk ratios than patients treated to higher LDL values. That gives us some information. If you want to look at the actual numbers, the percents from the same meta-analysis of cardiovascular events. If you look at red, that's just major coronary events. But in blue, which would be appropriate for a woman especially to also include stroke, we see those percentages too. And if we treat perhaps based on these data, on good meta-analyses, the most aggressive approach, and achieve an LDL of less than 50, it's associated with a risk of about 4.4% compared to her right now being about 16. Now these are meta-analyses, they're not going to give us all the answers, but I think that relationship of maybe treating more aggressively may give you more predicted reduction in cardiovascular events. You know, we went back and forth on agreeing on this. I think now with PCSK9 inhibitor data and even with the improvement that it supports that LDL lowering hypothesis. Perhaps that explains Anisa's aggressive approach. But I guess I sort of tip my hat a little bit. When I look at this patient, she does have stage 3 CKD. The NLA's approach, when you look at risk stratification, is to identify CKD, significant CKD like this patient, as a risk factor that will lead to a higher risk category and a more aggressive approach. In your practice, how do you consider CKD in your aggressiveness?
Well, it is an important part of your consideration. You know, why is she 54 years old, got a eGFR of 45? I mean, I would like to know your analysis. She got protein already. Is there some other issues going on? This is not going to be a good thing for her starting young at 54 years old. They do have higher risks of cardiovascular disease, and you know, it's not captured in the pooled cohort equation. And none of that with where her kidneys are and why they're at that point is captured in this. So I think, you know, this is, we talked about what other factors besides, you know, okay, she got hypertension, oh, and then she got CKD, so she's primary prevention with comorbidities, but she doesn't have diabetes. You know, I'd like to know, does she have protein in the urine? Is this something I'm going to worry about in the short run? Not just for her kidney function, but overall cardiovascular risk. Even at 54 years old, deciding on more intensive treatment for her, is this one where coordinated calcium might be a measure?
It might help you. Yeah.
Anybody think that might be something? If she had 0, you might just stick with 80 of Retorva, and if she had positive coordinated calcium at 54, you'd be more intensive? That's something to worry about?
Because if you're convinced to already treat more aggressively, you don't need another test. Maybe that's more for the people I call it on the fence, when you're not quite sure, or maybe the patient's giving you you really want to treat more aggressively and they're giving you some resistance. Sometimes it helps with that shared decision making. Or, because I'm always an advocate, if you've already made your decision to be aggressive, you don't need another test probably. But I think it does help some people to give you more information to make your treatment decision.
It can. I guess the question is, if you keep her on the statin dose and don't add anything, I mean, that's probably fair. But somebody wanted to add ezetimibe and as a treatment, that would certainly get her another 20-25% lower on LDL, which is really quite impressive. She'd be well under 70 milligrams per deciliter if she spawns appropriately. Any data that ezetimibe is okay in CKD?
Yes. And let's share some of that. And when you talk about CKD, actually, when you think about drug safety and CKD, as a pharmacist, this is where, you know, my tension goes up, right? CKD, I want to assure safety. When we think about just statins in general, we had this historic sort of reluctance to include CKD patients into long-term trials because of fear of an increased risk of muscle-related side effects. And because of that, a lot of trials systematically excluded people with kidney disease. One way to look at statin safety, if we just start there, in CKD, one pharmacologic perspective that's nice about her current treatment, which is atorvastatin, is the least dependent on renal elimination. Less than 2% of that drug is eliminated unchanged in the urine versus everything else is greater. And the other high intensity option being rosuvastatin might be fine, but that is eliminated 10% unchanged in the urine. So some people, as we look at drug elimination in patients with impaired kidney function and that characteristics of drug elimination to help influence our choice. So I'm happy with the atorvastatin, but we do have some data with CKD. You may think, oh, for those of you who are maybe thinking PCSK9 in this patient, there's some data that's evolving. These data come from the Odyssey trials, a pooled analysis that looked at alirocumab versus placebo or ezetimibe. And if you look at the populations on the left, there are patients with ASCVD and with estimated GFRs of less than 60. And if you look at overall, these are pooled data. This is not a definitive answer, sort of preliminary data, but there is a trend that there may be lower cardiovascular risk, similar to what we might see in patients with ASCVD and diabetes. This is not definitive by any means, but at least it's some suggestive data that perhaps CKD coupled with ASCVD may be in the right direction. This patient does not have ASCVD, they just have CKD, but I think this is what we have available right now with MACE endpoints, major adverse cardiovascular events, with the PCSK9 inhibitors. The one question that Dr. Jones asked, though, is do we have data with ezetimibe? Yeah, we do. And it's good safety data. So the one study that welcomed patients with CKD was the SHARP study. Almost 10,000, or a little over 9,000 patients in the study all had CKD. A third were on dialysis. 2/3 were pre-dialysis or just had impaired kidney function, impaired chronic kidney disease. And these patients who are primary prevention patients, after a period of years, placebo was compared to ezetimibe with simvastatin 20. And there was overall benefit at reducing cardiovascular events. But the question about safety is really important because that really was the early part of this study. This study at the end of the day, at the end of it, actually compared 2 drugs to nothing and showed benefit as far as cardiovascular event lowering. But the first year of this study was a safety analysis. And it really did prove that both simvastatin 20 alone and simvastatin with ezetimibe were considered safe. To the point where at the end of the study, when both those drugs were used together, we didn't see an increased risk of predictable or at least fearful adverse events that may be increased by the presence of CKD, like extra myalgias or a high excess rate of patients dropping out. So from a safety perspective in CKD, atorvastatin looks like a good drug. So does ezetimibe as far as safety. I would even throw in there, if you're looking for another statin that's really proven in CKD, we can go pharmacologically based on atorvastatin, but we also can look at simvastatin 20 milligrams, which was used in this particular study as being studied long-term in a CKD population.
So one question I have is the monoclonal antibody excreted in the kidney?
You know, I want to say no. I'm not 100% certain on that. Usually monoclonal antibodies, being large molecules, are not excreted unchanged in the urine at all. So I'm suspecting a very low incidence of that.
So if she were to progress slowly over the years and her eGFR reduces, you wouldn't need to necessarily, if you went to a PCSK9 or thought that was useful, and I'm not using her, but if you were to use it in someone with CKD, that probably wouldn't need to be dose adjusted, for instance. Same thing with ezetimibe, because they had some patients who had stage 5 CKD and it didn't seem to have any safety issues in them either. So, you know, I think those are good. Yes, question.
So the question is, any concern about using the max dose of atorva lowering HDL? Yeah, I tell you my take on that. That is a true thing that happens with atorvastatin that we don't see with other statins. Sort of, we have more HDL effects with lower doses than we do with high doses. And so I think it's one of those nice pharmacologic effects that I hate to say it doesn't really mean much, because we know that atorvastatin 80, based on multiple studies, does provide that cardiovascular event lowering. So it's one that maybe that reduction doesn't mean anything because it's superseded by the overall cardiovascular benefit. That's the way I look at that.
I agree. We're still not sure what HDL cholesterol means in the big picture on that end.